Hi, I'm Dr. Brian Shuch, Director of the UCLA Kidney Cancer Program, and I'm thrilled you can join us today to discuss this common topic about management options for the small renal mass. Many patients ask me, what are my treatment options for small renal tumors? And we'll discuss some of these options today. So a new diagnosis of a renal mass comes with a lot of challenging discussions to have with your doctor. There's a lot of uncertainty, there's a lot of anxiety. Patients often are confused because you want to ask your doctor, what is the correct treatment? However, we don't really have randomized trials comparing one therapy to another therapy. So a lot of this comes down to patient preference. With the diagnostic and management considerations, we can try to help you through this some of these confusing times. Determining the best treatment often relies on a lot of different factors. Understanding the type of tumor, the location of the tumor, the grade of the tumor, and the size. The type, there are actually 22 types of kidney cancers that are actually present. They all arise from the kidney and they're all somewhat different. The location, some tumors are a little bit more challenging than others because they might be deeper, they might be more central, they might be closer to critical structures. The grade is how we say how ugly a tumor is. Is it looked to be very high grade, meaning it looks nasty and wants to fly out of the kidney, or it looks low grade, looking very well behaved, meaning it probably will grow much slower and have a lower chance of spreading or invading. Or size, clearly the larger size, the more aggressive it is. The larger the tumor is, the less likely it is benign. So in understanding and determining the best treatment options, some factors we consider are patient characteristics, the health of the patient, their well-being, their longevity. Now, some patients want to ask us, should I get more information? And when you meet a patient, you try to understand, if I tell them it's a renal mass, I try to give them the risk that it is cancer. I try to tell them what's the chance it is a guppy, goldfish, or a shark, okay, meaning benign, indolent or wimpy, slow growing, or aggressive, nasty, the shark. So a tumor that is less than 4 centimeters, I try to risk stratify that into the risk of benign, indolent, or aggressive. Again, the benign is the guppy, the aggressive might be the shark, and most of them are low aggressive goldfish. And I always ask patients the first question, will knowledge of this more than just generalizable terms, will it help you? If a patient really wants to get more information, we can obtain more imaging. We have different tools here. We have biopsies. We have advanced nuclear medicine imaging tools. If a patient says, no, I don't need more information, I'm ready to make a treatment decision. Well, I would tell them after treatment, if we find out the tumor is benign or maybe cancer, will you have regret not knowing this? I have some patients that we take the tumor out and we say it's benign. Some say, hallelujah, I'm so thankful. Others say, well, I wish I knew this because I didn't want to or didn't need surgery. So it depends on this question. If you want to know before and this information would be leading to some regret later, then it's important for us to get that information first. Now, more information, what does that actually mean? What does it look like? Well, if you have a renal mass, more information could be a biopsy, it could be further imaging, it can help us better risk stratify that tumor. Again, some patients need that information to help make a choice of management. Other patients don't really need that information, and they say, doc, just tell me what should I do to manage this. And when we talk about management of a small renal mass, we have clear, good recommended approaches, which is either watch it, which is called active surveillance, burn it or freeze it, which is called needle ablation, cut the whole kidney out, which is called radical nephrectomy. We only usually do that for small tumors when the kidney is not working, or a partial nephrectomy where we just excise that kidney tumor. So again, when patients have a new renal mass, they're at a fork in the road and they sometimes need more information to help us make that decision. And more information could be, again, used to help with the management. But it's not always needed for all our patients. Now, the treatment options are very, again, straightforward. Watch it, cut it out, or freeze it or burn it for stage 1 kidney tumors. So again, the option 1, active surveillance, most tumors that are small do not grow quickly. Most tumors can initially be observed with low concern. And actually, if you look at some of these tumors, the ones that are more like guppies, they could be no growth on that first couple interval scans. And then there are patients that are sharks that are going to grow maybe more than 5 millimeters in that year, and those are going to be the minority. Those are going to be ones that are growing rapidly on that initial few scans. The most of our patients I consider having a goldfish, a tumor which could have some potential to cause harm, but really needs to grow big enough to do so. And the majority of tumors are going to grow between the 0 to 4 millimeters per year on annual growth rate. And over time, some of these tumors will declare themselves. If they were a shark initially, they'll show themselves. If they were a guppy, they're going to show themselves over time. And cure is still possible with active surveillance over 99% of the time, just with initial period of observation. However, some patients don't feel comfortable observing. There are some patients with a tumor less than 7 centimeters or 4 centimeters you want to do a partial nephrectomy on. They want to have us go in and take the tumor out. And removal of the tumor alone will be able to spare the majority of the kidney with partial nephrectomy. However, the chance of recurrence can vary from usually 2 to 8%. For the most part, the chance of local recurrence is low with a partial nephrectomy. And this does require general anesthesia and a short overnight hospital stay in general. But again, the majority of the kidney can be spared. This is a tumor which is a little bit bigger. It's a T1B, meaning it's over 4 centimeters. But you see that we can spare often the majority of the tumor, of the kidney with a partial nephrectomy. Now, a radical nephrectomy, again, for some tumors that are 4 centimeters that are not working or maybe situated in very tough locations, it may be advisable to have a radical nephrectomy. The complete removal of the kidney, the tumor, and the fat is called a radical nephrectomy again. This is a tumor which is about 4 centimeters. This patient had a tumor very deep. They were older and the other kidney worked healthy. And it was going to be a very challenging partial nephrectomy, and they didn't want to take that additional risk. And again, some patients losing that kidney function is going to be really inconsequential. So this is their radical nephrectomy specimen. Here's the kidney exposed because we spared their adrenal, and here's the fat all containing the lower and mid part of the kidney. The tumor is kind of buried, hiding within. That's a radical nephrectomy. And the final treatment option is needle ablation. So occasionally small tumors are in promising locations, often on the back part of the kidney, and we can access this by putting a needle in. And this needle potentially can be placed under image guidance. We can potentially use extreme heat to destroy a tumor with either cold or heat. And it can be either cryo, freezing, radiofrequency ablation, or microwave ablation to burn and kill a tumor. This can range in success from 70 to 95%, depending on the size and location. Often for tumors that are larger, the success is worse, maybe 75%. However, if it fails, often we can retreat with another needle ablation. Now, there is an emerging role in maybe some of these non-invasive modalities in the future, stereotactic radiation or high-intensity frequency ultrasound externally, but those are potentially things in the future, so stay tuned. Here's just a graphic representation of what happens with an ablation. There's a tumor here posteriorly. We might use kind of image ultrasound to start placing the needles, but basically the needles go in, and this one may be 2 needles, and this would be a cryo where you freeze with a ball of ice, and it would kill this area, hopefully completely. And you'd only know if it worked over time with imaging. So what management approach is right for you? Well, you should make sure your team has all the tools available and willing to discuss and entertain all options. Your clinician must be flexible to discuss what's right for you because, again, there are no right answers. There's only the right answer for you. Selecting management, you should be thoughtful. Sometimes a second opinion can be helpful. It's often about shared decision-making, understand your priorities. Is recovery a priority? Is trying to make sure that you have the tumor completely excised? These are important to consider. And be confident with the approach and find the doctor who's going to be best able to take care of you longitudinally because it's not a one-time treatment. Patients are followed long-term. And often a second opinion adds more clarity than confusion. You're always welcome to visit us at UCLA. Our program has been in existence for 30 years. Here's just some information. If you want, there's more videos that are available in our resource center. If you hover over the QR code, you can have access to our video library. If you want to help us make more videos or help support our extensive research program, you can also hover over this logo. More information is available on our webpage for treatment options or other providers. But thank you so much for your time and attention today.